Good morning and welcome to Child and Adolescent Psychiatry Grand Rounds. It's my distinct pleasure to introduce my friend and colleague, Dr. David Miklowitz. Dr. Miklowitz is Distinguished Professor of Psychiatry and Director of the Child and Adolescent Mood Disorders Program, or CHAMP, in the UCLA School of Medicine. He's also a visiting professor of psychiatry at Oxford University in the UK. Dr. Miklowitz's research focuses on family environmental factors and family interventions for kids and adults with bipolar or psychotic disorders, particularly those in the early stages of illness. His work has helped establish the effectiveness of psychosocial interventions as adjuncts to medication for bipolar disorder across the age range. Dr. Miklowitz has received numerous awards, too many to describe right now, but most importantly, perhaps, or most recently, the Distinguished Scientist Award from the Society for the Science of Clinical Psychology. And in 2020, the Mood Disorders Research Award from the American College of Psychiatry. And Dr. Miklowitz is one of only 3 psychologists who have received this award. He's received multiple research grants from NIMH and over 10 private foundations. And Dr. Miklowitz has published over 400 research articles and book chapters, including 8 books. The Bipolar Disorder Survival Guide is an international bestseller with over 350,000 copies in print, translated into 8 languages. His latest book, hot off the presses, is called Living Well with Bipolar Disorder, Practical Strategies for Improving Your Daily Life. So please, the other thing, Dr. Miklowitz, not on his bio, is that he is an extremely generous mentor, teacher, and colleague. He has launched the careers of numerous junior trainees, both psychology and psychiatry, many at UCLA who have gone on to productive research careers. So David, I will open it up to you.
Thank you very much, John, for that generous introduction. A special honor to be introduced by you, especially because when I came to UCLA, I basically decided I was going to imitate everything you did. And it's worked out well for me in terms of developing CHAMP and modeling it after the anxiety and tic disorders program. So thank you very much. As John mentioned, this is a talk on the role of the family in the treatment of early onset bipolar disorder. I don't have any commercial disclosures, but I do have some grant support to report from NIH, a couple of private foundations, and book royalties from Guilford Press and John Wiley and Sons. So there have been a couple of questions that have really sort of dogged me since I started this work, which was really in the I'm embarrassed to say, the early 1980s. One is, how is the family environment relevant to the course of bipolar disorder? I came from a lab at UCLA that was studying family environments in schizophrenia. I first became interested in bipolar disorder as a comparison to schizophrenia, but then became interested in it in its own right. Secondly, how does one design and test family interventions to alter the course of bipolar disorder? Is there anything one can do by combining family treatment with medications? Third, and this is, of course, a question all of us ask who do intervention research, what are the mechanisms? What are the core strategies to bring about change? What are we changing about the person, the family, the environment, the culture, whatever one is targeting? And does that have anything to do with outcome? And most recently, and I would say by most recently, really the last 10 years, my lab's been interested in family intervention as a preventative device to at least delay the onset of bipolar disorder in at-risk kids. So you'll see these questions kind of weave in and out of the talk. The lab I work in, of course, has to do with pediatric onset bipolar disorder, a much maligned category. People still debate how often it occurs. It was in some ways discovered here at UCLA by Mike Strober, the late Mike Strober and Gay Carlson in the early 1980s, who recognized that this disorder can occur much earlier than age 18. We now think it affects about 2% of kids and adolescents. We know those kids are at risk for a lot of poor outcomes, including suicide, social dysfunction. They have high rates of comorbidity. Most problematically, there's a long period before they're recognized, before their illness is recognized, often because they start with a depression, which is treated like just a depression, often with antidepressants, which may, in some cases, bring about mania. So this is the population we're interested in. Now, of course, one question comes up, how are these kids different from adults? Well, one way that question was answered was by Boris Birmerher at Pittsburgh, who compared long-term outcome in children and adolescents with bipolar disorder to a famous study done by Lou Judd that followed bipolar 1 adults over time. So the kids are in red, the adults are in blue, and just charted the number of weeks that each group spent in various states. What really stands out here is that the bipolar kids spend a little bit less time well, but most importantly, they spend more time in mixed or rapid cycling states and have more polarity changes per year. So changes from hypomania or mania to depression, what we call mood instability. So really what uh, distinguishes them from adults is this intensive mood instability, even between major episodes of mania or depression. I mentioned this because mood instability is going to be a key topic later in the talk. Now, I mentioned, how do we measure the family? How do you understand the family? The most traditional way of understanding stress or conflict in the family has been with this concept of expressed emotion. It's sort of a misnamed construct, EE. It's really a measure of attitudes, because the way you measure it is you interview a parent of a concurrently hospitalized or acutely ill bipolar adult or child and ask them about the history of the illness, how they feel about what the kid is doing, how it's affected the family. And you're looking for three dimensions: criticism, hostility, and emotional overinvolvement. How many critical comments do they make in a 1 hour interview? Those are usually statements like resentment or dislike or being bothered by. Hostility, disliking who the child is. I dislike the person he's become. I wish he'd never been born. That kind of very severe criticism. Or overprotectiveness, a little bit harder to define, but basically it's the same as enmeshment, the lack of boundaries between a parent and a kid. Example here, I don't invite people over because my son doesn't like it. His math homework makes him depressed, so I do all the problems for him. When you get enough information like this, you start wondering about emotional overprotectiveness. Okay, so this is how you might measure attitudes in the family. But what does this mean? Why do we do this? Well, one reason is because expressed emotion is a predictor of who has a relapse in say 9 month to 1 year follow-up. These are data from way back when, my dissertation actually, which was done on the inpatient units at UCLA. And what we found basically was that young adult bipolar patients, most of whom were manic, if they returned after the hospitalization to one of these highly critical or over-involved homes, their chances of having a recurrence within the next 9 months were about 90%. If it was a low key, less conflictual, less over-involved family, about 50%. And of course, this is a finding that's been replicated in many other disorders. Jonas Arno, for example, found the same thing in a sample of childhood depressives. Jill Hooley found the same thing in depressed patients. And of course, many people have found this relationship. Keith Nectarline, for example, in schizophrenia. So it's a well-validated finding. Now, what does this tell us, though, about how to intervene? Just knowing that a family is high in expressed emotion, how does this help us design an intervention? Because that's really what we're all about. Well, one way is that we've found in our work that high expressed emotion relatives are more likely to voice what we call controllability attributions toward the child. So if you watch them interact with each other, the high EE relatives will say things like, you could control this if you tried harder. You aren't trying hard enough. You could get to sleep earlier. You could do better on your schoolwork. This is within your control. And what's missing often is the psychoeducational target of knowing that this is a biologically, genetically based disorder that may or may not be fully under the kid's control. Another thing we've noticed is that high E families are characterized by attack, counterattack cycles when they talk to each other. You can actually measure this, how many volleys they have back and forth before someone calls it quits. And clearly in high EE families, those sequences, those attack counterattack cycles go on for much longer. That's one of the reasons we do communication training, which I'll define in a moment. Now, the offspring in these families, the ones who have bipolar disorder, whether they're adults or kids, often have high levels of mood instability and reactivity or aggression or oppositionality. You can see this in their interactions. They fight back. They're very verbally kind of assertive, not aggressive as much as assertive. They'll cut people off. They'll argue back. And of course, they elicit negativity from relatives. That's one of our targets as well, the affective stability of the child when in interaction with the parent. So you can learn a lot from expressed emotion and its correlates. Here's a recent study. This was just finished this year, looking at targets of FFT from expressed emotion off on the side to parent-offspring conflict to the teen's level of depression. These were children who had bipolar or unipolar parents who themselves had mood instability, depression, and so forth. Over a 27-week period, who got better, who got worse in terms of depression? Well, there was a pathway, a mediational pathway between EE, parent-offspring conflicts, and the level of depression or mood instability that the kid showed over 27 weeks. So there was a direct pathway from EE to outcome as well as through parent-offspring conflict. So when we think about EE, we really need to be thinking about the interactions between parents and kids and how clear, how likely to resolve those conflicts are. Now, what do we do about all this? So this is where we get into our treatment, which is family-focused therapy, something quite well known to our fellows and interns if they've gone through CHAMP. This is a model that consists of a couple of different components. In its current incarnation, it's 12 sessions long over 4 months. We go weekly and then biweekly. But its main components are psychoeducation, communication training, and problem solving. Now, what I mean by that, well, first we want to bring in the kid and do a diagnostic assessment. Patty Walshaw in our lab and others have really shepherded and supervised that part of the assessment to learn about the family, about the diagnosis of the kid, make sure this is really bipolar disorder or some other disorder. If we take them into the program, there are 3 modules. Psychoeducation, which is really teaching the family about the symptoms, early warning signs, treatment, and self-management of bipolar disorder. But unlike teaching, it's really more having a Socratic discussion with the family about their experiences. How have they seen bipolar disorder develop? What strategies have they used to try to control the cycling of the disorder, if they know? The capstone of this is developing a relapse prevention plan involving identifying early warning signs and going through the steps of generating self-management techniques or family management techniques that could be brought to bear if the kid is developing a new episode, which might simply be calling the physician for a medication change or implementing one that's been recommended before. Communication training is our most direct way of reducing expressed emotion, and that involves rehearsing in sessions effective speaking and listening strategies. So having one person talk while another person practices listening without interrupting, or asking someone else to change their behavior, or balancing positive and negative feedback, all through role playing. Finally, problem-solving skills. This is taken either for we apply this either for very specific problems families bring in, such as house isn't getting clean, all the way up to more deeper issues, such as he won't accept his disorder, or he won't take his medications, or mom nags me too much about my medications, or I don't want to see that psychiatrist. The problem solving involves teaching the steps of defining, generating solutions to, and evaluating solutions to problems. The therapist at this point is playing a minor role, and the family is using their skills. Now, let me give you kind of a deeper dive into what happens in this therapy, and this is kind of the more clinical part of the talk before we get to data. First, think about this word psychoeducation, which is really an amalgam of two words, psychological and education. It's not just the provision of information. You can go on a website and learn things like episodes of mania are often precipitated by changes in sleep wake cycles. Okay, we all know that, but that only goes so far. If we want to personalize that information to a patient, we want them to come up with something like, gee, that's interesting. The last two manic episodes I had came after periods when my sleep got way off because I was traveling. Patients come up with this sort of thing, so do their relatives after they've kind of thought through the information. But we want to go one step further, which is to practice an illness management strategy, which might involve a relapse prevention plan, including strategies for managing sleep wake cycles, getting rescue medications, looking at events in the family that may interfere with sleep wake cycles. So, really, it's going from information to the practice of alternative strategies. That's what we mean by psychoeducation. Patient is very active. As a matter of fact, we identify them as the expert in the disorder. Now, communication training, much different. We try to teach these 5 skills through modeling, practice in the sessions, offering feedback, having them go home and practice again. So active listening, keeping good eye contact, paraphrasing, making requests for change in a positive way rather than negative, balancing positive and negative feedback. Let me give you an example of what that actually looks like. So here's an example of communication training with a high EE father. This is actually a real session. I blurted out the names, of course. But in this case, this was a father who was highly critical, and we're trying to teach him one communication skill, making positive requests for change. It's a family with a father, a mother, and a 16-year-old boy with bipolar 1 disorder. Father starts by saying to his son, I really resent the hours you keep. You always come in later than we've agreed on. You're loud. You wake us all up. You don't take your illness seriously. Again, notice the criticism and the negative attribution. The son does the one size fits all response of adolescents. They roll their eyes. Whatever. I'll be out of here soon anyway. Father says, you have to choose to get to sleep on time so you don't go wacko again. Another attribution. This is under your control. Mom jumps in. Larry, that was only that one night. Father brings mother into the whole thing. You want to pay for another hospitalization? So dad is quite angry, arguing with families. Nobody's really listening to him. And this is typical of what we see in high E families. So what would we do in communication training? Well, first you have to kind of get on the side of the father. He feels won out because of this. He doesn't think anybody's listening to him. Maybe they aren't. So the first thing you have to do is validate the intent of his criticism through reframing. Dad, you really care about his health. You're worried about him having another episode. Dad will probably like that because that is the underlying desire. However, what you're saying may not be having the intended effect. It may be having the opposite effect on your son. Let me check with you, son. How's this landing for you? And the son is likely to say something about the negativity, the criticism. So we then ask dad to practice a skill, making a positive request. So instead of you got to stop coming home so you don't go wacko again, you encourage him to say something like, I'd appreciate it if you come home earlier. Let us know if you're held up. That would make me worry a lot less about you being safe, which is a lot easier to hear. That doesn't mean the kid will do it, but at least the message is there. And we check again with the son on the impact. Then we might go into a problem-solving discussion about what's reasonable in terms of the kids going out and dad checking on him. We would encourage them to practice this communication skill when these issues come up. So it gives you kind of a nutshell idea of some of the things we do in this treatment. This slide requires a little setup. When I was going up for tenure at Colorado, this was in 1993, a friend of mine and I, who was also going up for tenure at a time, had a bet. Can you summarize your whole career in one slide? He was studying rats, I think, rat whiskers and perceptions and so on. His was easy. He just set up a picture of a brain and showed a rat and arrows and so forth. Mine was a little trickier. What I did with mine was summarize the trials we had done on FFT with medications. We've now done 13 of them. And don't worry, I'm not going to go through all 13 of them. You'll die of boredom. But a quick summary. These design of these studies have generally been family-focused therapy plus medications versus some sort of brief psychoeducation or supportive therapy with medications. We call that enhanced care. So it's usually a briefer family education or some supportive therapy, but everybody gets the same mood stabilizers, antipsychotics, and so forth, usually delivered by a study psychiatrist. We've done 13 trials. 5 have been with adults, 2 with adolescents, 2 with kids at risk, 2 now with kids at clinical risk for psychosis. I'll mention that later. That's my work with Carrie Bearden and the CAPS program. We've done work in public mental health clinics, training their therapists, and one with teen offspring of parents with bipolar disorder or depression. Now, not all these studies have found exactly the same thing, but over studies, we found that FFT is associated with greater benefits in symptom severity, lower rates of recurrence, and better psychosocial functioning and quality of life compared to the comparison treatments over 1 to 2 year periods. And so this is promising. But again, this is comparing FFT to a less intensive treatment and keeping medication the same. Now, how do you take that a step further and try to ask, well, how does FFT do against other treatments that have been developed for bipolar disorder? In fact, there are some pretty good treatments developed for bipolar disorder. There's a form of CBT. There is IPSRT, which stands for interpersonal and social rhythm therapy, emphasizes sleep-wake cycles. There are various group psychoeducation treatments. Now, network meta-analysis allows you to compare diverse treatments that may not have been compared directly in any one study, but also to compare their components. So, for example, if 2 treatments both use cognitive restructuring, you can look at, well, what is the effect of cognitive restructuring separately from the treatment in which it's being delivered? We had 21 trials that we had to work with. And by we, by the way, I'm talking about my colleagues at Oxford. I was very fortunate to be able to go to Oxford in 2006 for a sabbatical, and I ended up staying there as a consultant for the next 12 years or so before the pandemic. And I got to work with Andrea Cipriani and his group, who are very good with this kind of analysis. We had 21 trials comparing pharmacotherapy and a manualized treatment to pharmacotherapy with treatment as usual, which was meds with clinical support. And basically, in a nutshell, our findings were as follows. First, all the manualized psychosocial treatments, which were CBT, family-focused therapy, interpersonal therapy, and group psychoeducation, all of them were associated with lower recurrence rates than treatment as usual. And in treatment as usual in all of these studies was either medication alone or medication with some sort of clinical support. So having the manualized treatment dropped recurrence rates by 44%. But also when we looked at the components, it was really psychoeducation with guided practice of skills that was the most powerful component. And interestingly, delivering psychoeducation in a family or a group format was more effective than doing the same psychoeducation in an individual format. Now, why might that be? Well, think about it in terms of the AA model. In AA, we think alcoholics do better because there's an advocate, a sponsor, who helps them out when they're getting ill, who is there in a crisis. Same way with bipolar disorder. A family member, another group member needs to know what a manic episode looks like in that person, to be available when that person's cycling. We think that makes it much more powerful to know what to do in the early course of escalation to mania. And that combination actually was very powerful in terms of reducing recurrences. So far, so good. But so far, I haven't said a whole lot about kids. So let me talk about kids at risk for bipolar disorder. By the way, this is my daughter, Ariana. She was about 21 year at the time. And I took this picture one time we were out walking and I said, could you give me your best bipolar face? She whipped around and gave me that face. I shot it. She allowed me to use a picture for this section, kids at risk for bipolar disorder. Now, what does that mean? What does that mean to be at risk for bipolar disorder? I wasn't the first one to come up with this. This was Horace Biermacher and his group at Pittsburgh defined what they called risk conditions, which are basically major depression or other specified bipolar disorder in a kid. So, or what we used to call BPNOS or BDNOS, subthreshold depression, subthreshold manias, not having as long episodes as one might expect. Also having a first or second degree relative with bipolar 1 or 2 disorder, and current hypomanic or depressive symptoms along with mood instability. This triumvirate is really very predictive of who in a group of kids will go on to develop bipolar 1 or 2 in a 5-year follow-up. So it's a group you can target for psychosocial preventative interventions. In fact, we followed a group like this in a treatment study. This was one of Mark Weintraub's papers, Journal of Affective Disorders. We followed a group of 126 high-risk kids who met those criteria. And interestingly, there were different outcomes. This is a latent classification analysis. And about 50% of them began ill, improved a little bit, but basically stayed ill. They had spent only 30% of their time well, and otherwise were depressed or rapid cycling or hypomanic. A group of about 17% stayed moderately well, but a good 1/3 of them got better. It wasn't only those who were in family therapy, they were in all sorts of different treatments, and including medications and other therapies. But about 1/3 of them looked well, even if they weren't taking medications by 3 years. And there now have been 3 or 4 labs that have found the same thing. Does seem to be a subgroup of high-risk kids who are ill during adolescence and look fine by the time they're in their early 20s. It's a little bit like what's been called in antisocial personality, adolescent-specific sociopathic behavior. It's very much like that. Kids start looking more stabilized. That doesn't mean they won't have another episode, but we do tell parents there's at least a 1 in 3 chance that your kid will look good and healthy within about 3 years, which is, of course, promising. Now, of course, what about, does FFT improve the outcomes of these kids who are at risk for bipolar disorder? And if so, by what mechanisms? So this is, of course, an early intervention study. We tried to prevent the onset. Our first study on this was a study of 12 sessions. We called it family-focused therapy for high-risk kids. We compared it again to a briefer psychoeducation called enhanced care, and simply looked over 52 weeks who recovered. They all came in with depressive or hypomanic symptoms. None of them were manic, of course. How long did it take them to get better? Well, the ones in FFT, all of them were better by about 29 weeks. They recovered an average of about 11 weeks. The group that had enhanced care took longer to recover. Most of them recovered, but a good 35% did not, and it took them on average 21 weeks. Not a huge difference, but does suggest that the family treatment hastened recovery. What I find most interesting about this, though, is if you look in the lower right-hand corner, we broke it out by high and low expressed emotion families. And the hazard ratio for recovery was much higher in the high EE group. In other words, those from high EE families were more likely to recover more quickly than those in low EE families, particularly if they got the family-focused therapy. So one subgroup that may do particularly well are those with the families with the most conflict and most criticism, most tension in face-to-face interactions. All right, but that was only an N of 40, so we did a much larger collaborative R01 on the same question. This time we matched the enhanced care on duration. We still didn't have the same number of sessions, but each treatment lasted 4 months. So family therapy versus 6 sessions of family and individual education. These were 127 kids. We were allowed them to be on whatever medications they needed. In fact, we had our own docs who did a pharmacotherapy algorithm, followed them for almost 4 years. And in this case, due to some collaboration, we were able to do some pre-post neuroimaging as well. This was done at UCLA, Stanford, and Colorado. Here's the main finding. The group that got FFT, again, this is how many survived without a new recurrence. How long did it take before they had another episode of depression or hypomania or even mania? Those in FFT lasted longer. They lasted on average 81 weeks before having a depressive episode or a hypomanic episode. Those in the EC took less time to have a recurrence. So in other words, we're elongating periods of wellness with this treatment for early onset patients. Mark Weintraub did some mediational analysis to kind of look at what is actually changing in the family. And one of the things, not surprisingly, that we found was family functioning, that if you got the family treatment, the kids' ratings of family functioning improved. They got better. They had less conflicts, and when the family had less conflicts, the depression levels went down. It was a direct mediational relationship. The treatment was effective. It went to non-effective or non-significant when you introduced the family functioning variable. So that's one of our targets: is how disturbed is the family, how well do conflicts get resolved. If we can improve that state, we can improve that environment, we may see more improvement in functioning and in depression over time. Now, let's look at a different level, the brain. What's changing in the brains of these high-risk kids? I was fortunate to develop a collaboration with some folks at Stanford, Manpreet Singh, Amy Garrett, who was there at the time, of course, our own Patty Walshaw, an expert in neuroimaging, and Kiki Chang at Stanford. And we designed a study that looked at corticolimbic circuits before and after getting either FFT or the comparison. Now, we used an implicit emotion perception task. What that is it's that emotion faces task, what many of you know as the NIM-STIM data set, where you have faces showing different emotions: happy, calm, angry, fearful. And your task is simply to say, is this a male or a female face? So it's really an implicit emotion perception. You don't label the emotion, you label the gender. And then you can look at neural activation in different regions of interest. When the kid is looking, for example, at a fearful face versus a calm face, or an angry face versus a calm face. We could look before and after the treatments and ask, do levels of neural activation predict treatment response? And we weren't the first ones to do this. Bipolar disorder had been linked with amygdala hyperactivity and prefrontal cortical underactivity, which was our hypothesis that we'd see changes in that circuit. The findings, I'm going to summarize a lot of findings in a short time. We had two analyses. One was of the NIM-STIM face recognition task. That was done by Amy Garrett, who found that in the face processing task, we saw an increase in dorsolateral prefrontal cortex activation, a very important circuit in emotion regulation, memory, inhibition, and other circuitry, and increases in DLPFC activation mapped onto reductions in depressive symptoms. In the resting state, as Manpreet Singh and her colleagues found, we saw greater connectivity between right VLPFC, ventrolateral prefrontal cortex, and the anterior default mode network in the FFT condition, which then mapped onto improvement in mood lability and depression. That circuit, or RBLPFC and to DMN, has been hypothesized to be important in self-awareness, illness awareness, and emotion regulation, some of the very things we try to teach in FFT. This is a small study. There were only about 36 kids in this, analyzed it pre and post. And I think we're going to have to replicate this and show that these changes in neuroimaging results map onto learning skills that we think are important in the treatment. Okay, take a deep breath here. And let me deal with the last issue, which is how to integrate digital mental health into this treatment. So right around right before the pandemic, really, we became aware of the interest in NIH and in other public agencies in making treatments available by app. I was very skeptical that a treatment like FFT could be appified. Um, and I've always been a big believer in there needing to be a person there, and I'm still a big believer in that. Nevertheless, we worked with Armin Arabian, who was in our department at the time, who was quite a good app builder, and tried to see if we could solve the problem that kids and parents are reluctant to practice skills between sessions. Does adding a skill training app to FFT make it more effective? Now, what we decided to do was to give everyone the 12 sessions of FFT, but to vary the apps. And basically, the apps could either be skill training focused, meaning there would be reminders, for example, to practice your communication skills, or reviews of the last session, or here's what it means to solve a problem, and encouragement to kind of log one's efforts on the app, versus a more simplified app, which was track your mood on a daily basis, which patients were more used to doing. We had 65 kids who had either depressed or bipolar parents in this study. We called them high risk, but they in fact had depression and mood instability already. These kids, they were about 16 years old on average, 15, and already had some depression and mood instability. This is a sort of overly detailed view of the app, but you can see here the skill-oriented app asks the kid and parent to review one skill every week, like active listening, making a positive request for change, solving a problem, doing some behavioral activation exercises, and then recording it on the app. And the clinician can see, did you do your homework? How consistent are the families? And that's one question we had was, would people practice these skills more often if they were prompted to do it on the app and asked to record their efforts? Other than that, they just kept track of their mood, their stress, family relationships, and so forth. So two findings I want to highlight. First, what about in the 65 group of 63 kids, all of whom had some sort of app? Did they do any better than some of the kids we had in our earlier trials who were just getting FFT without an app? Now, this is not a randomized comparison. This is a comparison of one study with another. We matched the kids as closely as we can, but of course, you'd have to verify this with a randomized trial. But basically, what we found is that the change from baseline to 4 months in depression was larger if they were using some kind of an app, either tracking their moods or doing the skill training via rehearsal because of the reminders on the app. So that was promising. The more detailed analysis that Mark Weintraub just published in Bipolar Disorders found that there was a mediation factor, which was skill practice. If the therapist would rate these kids and the parents on how often they practiced skills every week, how often they practiced each of those skills and developed a latent variable. That turned out to be a mediator of whether we saw differences, in this case, in children's affective lability scale scores, which is our measure of mood instability. The same results came up for family conflict. If they practiced these skills, they showed less conflict over time. So there is some reason to believe that adding an app will, for some people, increase their practice. And if they do increase their practice, they're going to see a better family environment and more stable moods over time. This study was 27 weeks long. A lot of other variables played a role in this, of course, but skill practice was one of them. Finally, I want to just mention something some of you may have heard of, our Child and Adolescent Bipolar Network, which we're calling CABIN for short. It's a group of 5 university sites that have gotten together to try to answer some questions about pediatric bipolar disorder. Uh, this was done with some funding from what's called the Bazooki Brain Research Fund. This is a group of private donors who are interested in ketogenic diets, metabolic indicators, collaborative studies of bipolar disorder primarily. And they gave us some funding basically to put this network together and try to answer some basic questions. This is the group of people who I'm working with: Cincinnati, Pittsburgh, Colorado, and Virginia Commonwealth, a great group of people. We meet every 2 weeks. And what are we trying to do? Well, one thing is to try to see if we can all diagnose bipolar disorder the same way. Bring in have tapes of some of these more complicated diagnostic cases where it might be bipolar disorder, it might be borderline personality, it might be autism, might just be ADHD. And can experts decide whether this is bipolar disorder or not? That's something I think that's missing in our field. Most of the studies are single site. Not very many studies have been done with multiple sites with diagnostic reliability. Also, are psychiatrists consistent in what medications they choose? We got together and developed a pharmacotherapy guideline. Here are the things you'd start with first. Then you'd move to this if that wasn't working. Where is lithium in relation to antipsychotics? When do you use an antidepressant? And what about if there's comorbid ADHD? Is it safe to use a stimulant? If so, when? So these kinds of questions, we're trying to look over the course of 1 year in pediatric bipolar kids. And interestingly, one focused question we have is about this whole mood instability construct, to try to define what we mean by mood instability and how it's different than just going from manic to depressive episodes. You might remember early on, I showed that slide from Boris Biermacher's work, where there were so many polarity switches in kids versus adults. What does this mean? What is mood instability? The way we've been defining mood instability, we've been thinking about it as an endophenotype for bipolar disorder, meaning something that characterizes kids even between episodes. That's not to say that it's only bipolar kids who have mood instability. We know that isn't true. We know that ADHD kids have it, that kids with autism spectrum have it. So it's a fairly transdiagnostic, is the term, construct, but it's certainly true in bipolar disorder and has been found to be a predictor of who develops the full syndrome among kids. Usually, the way we've rated it is simply to give a quick questionnaire to parents. The questions basically are: rate the following on a 0 to 4 scale. How many times a day does he suddenly lose interest in what she's doing, suddenly lose her temper, break into bursts of silliness or laughing, get very angry? Notice how many times suddenly or bursts of or unexpectedly are the key words in all this. Things that you're not expecting suddenly change. So you can get a total score from this. And actually, total scores on mood instability track very well with hypomania and depression ratings. So the green line here is kids' mood instability ratings versus their depression and hypomania ratings over almost 48 weeks. And you can see that when the kid is symptomatic in one direction, they are also unstable in mood. But even when they're in relative remission, that's towards the end of the follow-up, they still have mood instability. And that's one thing that really bothers parents, is the fact that their kid is not stable, even though they're on medications, even though they're getting therapy, they're still going up and down. So how do you measure this other than just giving a questionnaire to parents? Well, one of the people in our group, Annabelle Salimian, have been looking at some data on ecological momentary assessments. She did this with Megan Ichinose, and looking at if you, let's say, we ping a kid every 3 hours, can they rate their mood every 3 hours over a 6-day period? Got to pay them to do this, not surprisingly. Kids are not that wild about rating their moods. But the way we did is we sent them 8 emotion words, like happy, mad, sad, joyful, and so on, and asked them just to rate these on a 0 to 4 scale every 3 hours. What really stands out to me about this is, in this particular kid, there's so much variability in mood. And also, this kid often experiences seemingly opposite states at once: sadness and happiness, anger and happiness, being mad and happy, being mad, sad. All these things can go together with each other. They're not opposite ends of a pole. So this is one way, is simply to ping the kid. Oh, of course, you might be getting them at a bad time. That's the limit of this method. You might just be getting a bad 6 to 8 week. You can also ask the parents. This is something we call the POWERS, the Parents Online Weekly Evaluation, where we ask parents to rate every week on these dimensions like mania, depression, anxiety, ADHD. And you can see there's quite a bit of up and down movement even when parents rate these kids over weeks. And I also found it interesting that parents don't necessarily make the same distinctions we make between mania and depression, or mania and ADHD, because they often rated them as escalated on depression, anxiety, ADHD, and defiance all in the same week. So that's one thing we're learning, is that we can teach parents about these distinctions. It's not what they necessarily see when we ask them to rate these moods on paper. You can also rate their medications. In this case, the kid was on Lamictal, and then the dosage was increased and methylphenidate was added. You can eventually look over time at what medications are working, which aren't. So these are ways of getting at mood instability as a construct. So take homes from the talk today. First, what is the role of the family in the onset, of course, of bipolar disorder and these high-risk conditions? I hope I've convinced you. I know I've been talking very fast. I'm trying to model what pressure of speech looks like. Family processes are relevant risk and protective factors in people with or high risk for bipolar disorder. The expressed emotion research, the work on family interactions, involving patients and families in FFT, in psychoeducation, communication training, problem solving, enhances clinical outcomes, whether the patient is older or younger. We've done this treatment with elderly folks, we've done them with young kids across the age range. Changes in family communication and maybe even neural activity related to emotion processing may mediate the effects of family therapy on mood outcomes. We saw the results on family impairment, family functioning, being a mediator, as well as neural activity and dorsolateral prefrontal cortex, and that VLPFC to default mode network connection. And finally, mood instability may be an important endophenotype in this disorder, and one I think we should be all alerted to when we have somebody who also has a family history of bipolar disorder. I want to just briefly mention some studies we have going in our lab in collaborations. Many of you know about the study we call Uplift, Understanding Prodromes and Lessening Illness with Family Therapy. This is a collaboration between CHAMP and CAPS, Carrie Bearden's lab. We got an NIH grant some 4 years ago to do a 7-site study comparing FFT with a comparison group for these adolescents and young adults who have psychosis risk syndromes. So attenuated psychosis symptoms, brief intermittent psychosis, genetic risk, deterioration in functioning, the ways they define these kids who have a reasonable chance of going on to converting to psychosis. These kids, we have 224 who finished the trial. We're following them now. We've randomized them. We have a 6-month treatment retention of 85%. And we're going to be able to look at, does improvement in family communication mediate outcomes in this treatment of prodromal psychosis. Here's a quick schematic. We have kids who enter into FFT or enhanced care. We block on how low or high risk they are for conversion based on a risk calculator. We look at family interactions. The treatment is 6 months long. Bring them back from family interaction, follow them up to 18 months. So we'll have results from that, I would guess, within the next year, I hope. Also going on, we're starting a 4-site study of ketogenic diet therapies for adolescents and young adults with bipolar disorder. The Bazuki Foundation is interested in this. I'm looking forward to this with some trepidation because we want to make sure we can actually talk adolescents and kids into doing these diets. But I have a feeling that it may lead to lower medication regimens or less of a need for intensive medication regimens, which in itself might be reinforcing for staying on these diets. We'll see. And also, we are looking at mechanisms involving the gut and inflammatory markers. Mark Weintraub is doing a study on psilocybin-assisted CBT for adults with major depressive disorder that some of you are involved in. Natalie Ramos has funding from NIDA to do a study of FFT for adolescents with gender dysphoria. She's working with Danielle Denany and the Empower Group for kids who have family conflict, often suicidality and substance abuse, sometimes related to gender dysphoria. And recently, Lauren Eel has joined as a T32, and she is doing some work on social media and depression in adolescents. So this is a very active time for our lab. One piece of shameless self-advertising. This is the book that John mentioned, Living Well with Bipolar Disorder, Practical Strategies for Improving Your Daily Life. I think this is one way you can get treatments out in the community is simply to write a book for the public about what you've learned from your research. I wouldn't want to only write these kinds of books, but it's one way of getting the message out. And I have a lot of people to thank, all the people in CHAMP. Hope I've mentioned almost everybody. I had some great collaborators over the years in CHAMP, as well as my earlier times in Colorado and at Oxford, and funding from various organizations. So let me stop there and thank you for your time, and happy to take questions. Please put them in the Q&A, and we'll get to them. Thanks very much.
Thanks, David. That was a really great talk. So much information and so much productivity from you and your group addressing these really critical issues. A couple of questions are coming in, and this is a question of mine. I love the, looking at the conflict, expressed emotion as mediators of the work that you're doing. Do you also measure parental psychopathology? And I'm wondering how that might relate to the family conflict, either as a target or an additional mediator or what?
A very interesting question. And in fact, the most recent sample I showed actually had parents that had mood disorders and their kids. Interestingly, we've never found a direct relationship between the parents' diagnosis and their expressed emotion or their interaction patterns. That surprised me. I would have thought that would be true. The only thing that has come out has been the more anxious parents are more likely to be emotionally overinvolved, which is not too surprising. But it's not like you have a parent who's, floridly manic in there who's criticizing the kid because of their own emotional dysregulation. Nevertheless, I don't doubt that plays a role. If the parent is currently depressed, they may come up with more criticisms or more conflict. Documenting it, we've had a tough time showing that the parents, that relates to expressed emotion. What we haven't done, though, is looked at whether or not parents get better as a result of the treatment. That's another side of that question.
Okay, great. How do you differentiate the emotional instability in bipolar from psychosis? And I'm really interested in the study you're doing with Carrie. What are the commonalities and the distinctions, and how easy are they to tease apart?
You ask a lot of easy questions, don't you? The mood instability construct, at least the way it's been operationalized with that scale, there are three kinds. There's elated, manic type mood instability, where kids are going from depressed or angry to silly or giddy. Frequently, there's an irritability style, and there's an anxious depressed style, just going from feeling okay to being depressed and crying and withdrawn and so on. What I would expect, and we haven't looked at this yet, but I would expect what we would see more in the psychosis is more of the irritability, the switch from seeming to be okay and suddenly getting very angry at something when things don't go your way or when there's a change of plans, that you'd see this sudden flying into anger. You wouldn't necessarily see giddiness or elation, which I think is a more specific bipolar feature. It may show up to some extent in ADHD, but not to the extent you would in bipolar disorder. So I'd be looking at either irritability changes or depression.
Great, thank you. Another question asked, you know, disseminating this work into the community. So, you've done a lot of work with collaborators and broad reach and all, but is it possible, or have you tried to do broader trainings handing off the treatment? And how far can you get away from the clinic into the community with this?
Yeah. So a couple of years ago, we did an implementation study in two settings: D.D. Hirsch Mental Health Center and Harbor, UCLA, the outpatient division there. And D.D. Hirsch in particular, they had community therapists and often a very down and out population, mostly Medi-Cal or LADMH. And there were some interesting findings. One is that I think, the clinicians were fine in learning the treatment. I think a lot of them came in anxious about working with families. They'd worked with families, but the most they'd done was kind of treatment planning, where you bring in a family and talk about what medications the kid is on. They hadn't really done work on communication styles or changing family dynamics. So that was part of the resistance, I think, was just lack of familiarity with families, family therapy. The other thing was the patients. And the patients often didn't have families. They were, if they could be teenagers and either living on their own, or they didn't want to have anything to do with their parents, or their parents were working two jobs and couldn't possibly get in. And I think one of the things we found is the no-show rate was high, the dropout rate was high. We were able to finish treatment with a subgroup, but it wasn't anything like working in a university setting. So I think that's really true. Does this treatment work, or is it like a lot of treatments that as soon as you get it out in the community, the effects start falling apart because people don't follow the manual or the patients don't show up? So we do as many trainings as we can, just like you. We're always running off and training someone in this treatment, and I hope some people are using parts of it. I think there's a lot more we could do.
Um, Another question: was the app the sole treatment or an adjunct to clinic treatment?
It was an adjunct to clinic treatment. In that study, everybody got 12 sessions of FFT, and we randomized them to either the skill training app or the mood tracking app. I actually didn't want to do the study that way. It was something that NIH told us we had to do, basically, was to compare one app to another rather than what I wanted to do, which was to have one group with an app and one group without, so we could find out the app, the added value of the app. But they brought up, and it's a reasonable point, that just having an app on a daily basis may in itself have a therapeutic value, even if it were World of Warcraft or something like that. Maybe that would have been a better comparison. But then, of course, they would have used it twice as much as the Apple gave them. So, yeah.
Yeah, if you did World of Warcraft, forget it.
Yeah, we would. And actually, that was an issue we ran into all the way through, was that, if kids had a choice between using an app they wanted to use and using this one, guess which one worked out? One out.
Yeah, good. Another question. Great talk. Since we see very high rates of identification of diverse gender identities in CHR, wondering if there are specific assessment measures and or adaptations of FFT for the gender dysphoria trial that we should be considering for or potentially implementing.
Very good question. Natalie Ramos has shepherded that study, which is on gender dysphoria in the Empower Clinic. She really developed a whole new set of handouts for doing the psychoeducation. The communication training and problem solving is pretty much the same, but the psychoeducation is very different. So you have kids talking about what it means to be gender dysphoric, or what their confusions are about, why they want to be called they, them, or different pronouns, why it's important for people to ask about pronouns, educate parents about what they're going through. And when the tricky part, of course, is getting kids to talk to their parents about what this means, because many of them are afraid of rejection, which is the very reason sometimes they're going out and smoking weed and feeling suicidal and feeling depressed because they feel very alone. So the idea is to open up communication between them. But I think if somebody wants to try this in prodromal psychosis, we have a whole battery of handouts they're welcome to use. I'd like to see that happen, actually.
That's fantastic. We are running over time, so I think it's good to stop here. Carrie thanked you in the chat for your very helpful response and suggested we should have Natalia present to us on that topic. But what an amazing body of work in such an important area. So really fantastic talk. Thank you.
Thank you.
Thank
I
you
really
all for being
appreciate
here.
it. Thank you for moderating, John, very much. Have a good day.